Anesthesia in gestational diabetes mellitus. Welcome to this chapter. My name is Dr. Janvi, and today we are going to discuss about what are the usual implications of diabetes, and from there we will move on to what does diabetes do in pregnant patients. So there is a whole chapter that we have dedicated on diabetes, its complications and its management intraoperatively. That's almost a 1.5 hour lecture and it covers everything regarding diabetes. The only part that was left over there was how do you manage diabetes during pregnancy, and that's what we will be doing here today. So the first part of this lecture is going to be a quick recap of what we learned over there, the usual physiological changes in DM and the systemic complications, and from there we will move on to the part of gestational diabetes mellitus. First thing, what is the definition of diabetes? The definition of diabetes is given in terms of three things. One is if the patient has carbohydrate intolerance, which is shown in the form of HbA1c, fasting blood sugar level and postprandial blood sugar level. This postprandial blood sugar level is after 2 hours of having oral glucose tolerance test with 75 grams of glucose. So, if the HbA1c is more than or equal to 6.5, if the fasting blood sugar is more than or equal to 126 mg per dl, and if the postprandial blood sugar level is more than 200 mg per dl. This is when I say that my patient has diabetes. Okay. When do I say that my patient has impaired glucose tolerance? That means he is not normal, but till now he is not diabetic also. He is somewhere in the range of developing diabetes. So, in impaired glucose tolerance, my patient's HbA1c will be between 5.7 to 6.4. Fasting blood sugar will be between 100 to 126 and postprandial blood sugar level will be between 140 to 199. Okay, so you got the definitions of IGT as well as diabetes. Now let's move on to classification of diabetes. So as we all know, diabetes can be classified into type 1 and type 2. These are the first two classifications. Along with this, there are two other types of diabetes. One is secondary diabetes, and after that we have gestational diabetes. So, type 1 diabetes, what happens in that? This is your pancreas, this is your islet of Langerhans containing beta cells which produce insulin. So, there will be destruction of this beta cells as a result of the antibodies, okay. So, this is autoimmune diabetes, and in this there is reduced production of insulin as the beta cell is destroyed. So, in this we have to give insulin externally to the patient. This is insulin dependent diabetes mellitus. What happens in type 2 in most of the cases? Beta cells are producing insulin, but the receptors show resistance. So, if the insulin receptors show resistance, this insulin cannot act on the receptor. So, this is called as non-insulin dependent diabetes mellitus. Here we try to improve the peripheral resistance to insulin, reduce the resistance, increase the sensitivity, and other thing to do is to increase the insulin level so that it acts on these receptors. Then we have secondary diabetes. This is as a result of hyperglycemia secondary to disorders like Cushing's disease, pheochromocytoma, hyperthyroidism, and finally we have gestational diabetes, and this is what we will be discussing today. Gestational diabetes, why does it happen, what are the physiological changes, and how do we manage it. So let's have a look at diabetes and its systemic complications. Why am I focusing on this segment is because all of these systemic complications will be seen in a pregnant patient also when she develops GDM. So all of these need to be taken into account. What happens to the cardiovascular system? Now all patients of diabetes, as you know, they have increased risk of atherosclerosis. Atheroma formation in them is very quick. So as a result of this, they can easily get coronary artery disease. So chances of IHD in them increase. Second problem that happens in them is autonomic dysfunction. Okay. Now this autonomic dysfunction happens as a result of autonomic neuropathy. The autonomic nervous system basically consists of two parts. You have the sympathetic and you have the parasympathetic system. The sympathetic system is responsible for the fight and flight mechanism, maintaining the heart rate, blood pressure, all of those things in case of an emergency situation. The parasympathetic system maintains the homeostasis of our body, mainly by the stimuli given by the vagus nerve. So, in case of these patients, this autonomic nervous system does not act properly, it is abnormal. So, even if I give a small stimulus that increases heart rate, for example, on laryngoscopy we all know that there is tachycardia and hypertension. In a normal patient, the heart rate will increase from 80 to 100. But in a patient of autonomic dysfunction, the heart rate will have an exaggerated response. It will increase from 80 to 150. Similarly, blood pressure will rise from 100 to 200. Okay, so because of that exaggerated response, I can get problems intraoperatively. The other problem with autonomic dysfunction is I can get a silent MI in these patients. Silent MI means usually when an ischemia is developing in the heart, when the patient is having myocardial infarction, the sensation is carried by the sensory afferents and the patient feels a constricting type of pain in the left side of the chest, in the jaw and in the left arm. But in case of diabetic patients with autonomic neuropathy, this is not felt. So, they do not end up giving any symptoms and directly you will see ECG changes and hemodynamic instability. So, that is called as silent MI. Next, what happens to the kidneys? First of all, remember diabetes is an immunosuppressed state. The patient has high chances of developing secondary infections. So, out of those, the most common infections that a diabetic patient does get are urinary tract infections. Second thing in diabetes, you have diabetic nephropathy. There are changes in the parenchyma of the kidney, there are changes in the renal tubules and all of these lead to increased loss of albumin through the urine. So, you will see microalbuminuria in them. So, whenever you ask a diabetic patient, someone with uncontrolled diabetes, what is the color of your urine? Or you take a urine sample, you will see that the urine is quite frothy. Now, that frothy urine is because of the albumin or the proteinuria that is happening. Normally, protein should not be lost in the urine, but in these cases, because of the kidney damage, there is breakdown and there is loss, there is breakdown of the tubular membranes and there is loss of albumin through them. Now, this microalbuminuria further reduces the plasma protein levels. So, you have reduced oncotic pressure in them, and if you have reduced oncotic pressure, the fluid from all the blood vessels tends to move outside. Okay? So, you will see that these patients often have edema. So, these are the problems that I will see in a case of diabetes with regards to kidney.